Okay, so we're just going to do some anatomy and physiology. I made these years and years and years ago. They're laminated. They have little black dots on them because we do play pin the name on the lungs and other things, but we're not going to play that game today, right now. Instead, we're just going to go through the anatomy. And this is relatively basic. This is found in your MFR books. So this is the big giant tube after we know that from the mouth, here we go with my drawings, that's a witch nose. Oh. What's that, Bonnie?
It's a crown.
I am terrible at drawing.
It looks like Batman gone wrong.
Whatever.
It's
So
getting worse.
we know that our mouth and nose link together, but then it separates into two tubes. Okay. So mouth, nose. Anybody remember what this general area is called?
Are you looking for pharynx or larynx?
Pharynx, yeah. So in this general area, the back of the mouth, back of the throat, that's the pharynx. We have epiglottis. So with the epiglottis, it's the little flap door that prevents stuff from going down into your lungs when it's not supposed to. Basically, right in this area is the larynx. Okay. Not like that's huge, important stuff to know, but now you know the difference. If someone says, it's in their pharynx. Okay, so it's in the back of the mouth, back of the throat. You probably should be able to see it if you look with a flashlight deep enough, okay? If they say, oh, I have a tumor in my larynx, unless you're planning to like really stuff your head inside their mouth, you're probably not gonna see it with a naked eye, okay? But the epiglottis, so the epiglottis is literally right here on this drawing. What is this big tube below the epiglottis called? The trachea. Trachea. At the bottom of the trachea, it separates into, this is the patient's right lung, and this is their left lung. So the next one is the bronchus.
Bronchus.
Yes. And then the bronchi and the bronchioles. So bronchus. Bronchi is like, if you think about this, I always think of it as like an upside down tree.
Yeah.
Okay? So this is your trunk. The bronchus is your main, like, I'm gonna climb the tree and sit on the big giant limbs. Okay? Now the bronchi are like the, it might support my weight if I go a little farther off of this big thick thing I'm sitting on. The branches, yeah, branches, that's the right word. And then it goes to the
Leaves.
the bronchioles, which is the twigs. The twigs. Okay. At the bottom of all the twigs,
It's a seed.
look, this is like a magnifying glass. Whoosh. There's these little bundles of grapes called the alveoli. And what happens in the alveoli again?
Oxygen.
Oxygen, carbon dioxide exchange, and other gases, right? Like when we say oxygen, every time we breathe in, just for fun, how much oxygen is in atmospheric air? 21%. That's right. What's actually the gas that is the most in the air we're breathing? Nitrogen, yeah. So that also goes in, and some of that can be transferred as well, but our body needs oxygen, so hopefully the majority of the gas that you're taking in is oxygen. Again, what comes out? Usually carbon dioxide, your waste products, and of course, if you had absorbed nitrogen, your body's not going to use the nitrogen, it's going to come out afterwards as well. Okay? So there's a couple other little black dots here that are like, ooh, what are those things? So this one, very simple, is the lung. You have two. And then we have this little guy,
Pleural space?
not pleural space. Oh my God, I thought I saw somebody outside the window.
This place is haunted.
I know. let's just look at this one first. So you'll notice this black dot is on the meat or the tissue right there. So just like everything last week I talked about, every organ in your body has a bag around it. The pleura is a giant sac around the lungs. So the pleural space, as Chad is saying, is the space that has synovial fluid, so lubricant, that lives in here. That makes it so that when you breathe in and out, the tissue of the lung doesn't rub against like the heart and the inside of your ribs and everything else. So it's like the protective sac. Think of this as, we've all had sex ed. The embryo sits inside of a amniotic bag full of amniotic fluid to protect the fetus when mom's like running and jogging and walking and existing, right? So this space, the pleural space, is this guy. I didn't really leave a lot of room to write on there, did I? So the pleural space is in this negative pressure space that exists. Make sense?
Yeah.
What's this big guy down here? Diaphragm.
Sorry, so where was the pleura?
So the pleura is on the outside. So the pleura is ultimately a sac. Think of it like a big, giant bag of goo. And the
So
lungs
basically it runs around the whole outside.
exactly. It protects the lungs all the way around. Make sense?
You'd have to cut into the sac to see the lungs.
Yes. Just like when baby's born, the amniotic sac needs to be cut into so baby can come forth and you can enjoy it for at least 18 years of your life, hopefully. Okay? Now, question for you. We talked last week about pericarditis. Anybody remember what pericarditis?
Around the heart.
Inflammation of the sac around the heart.
Okay.
So knowing that round, carditis, heart sac, inflammation, what do you think it would be called if there was inflammation or yuck accumulating in this pleural space?
Pleural pericarditis.
So if it's pus, it's called a pleural effusion. So it's just like goo. If it's not this thickened, pussy, gross stuff, and it's just simple inflammation or an accumulation of fluid, extra fluid in there, I feel like I spelled that wrong, but pleurisy. So those of you, it's actually relatively common, not like, oh, I have it every year, but it's pretty common for the public to have experienced pleurisy at some time in their life. And it's just simply a buildup of the fluid. Understand that?
Thank you, come again.
Okay. We can see our general layout. Now, something that I didn't do a great job showing you here is, again, where is the heart in relation to this? So if the trachea, we know that the trachea sits right in the middle of our throat and it comes down and it basically hides behind the sternum. Where did we learn the heart was again? Just offset. So it's kind of like right here. Which means later on when we practice listening to lung sounds, you can listen to 3 different lobes on the right side, right lung, but there's only 2 lobes on the left lung because the heart kind of makes it so the lung is not as large. Okay? Knowing that as well, this little black dot here, that little guy is called the carina. The carina is the bifurcation from your trachea down into your right or your left lung. Now,
Sorry, how is that spelled?
C-O-R-I-N-A. So we're going to go back to my amazing drawing skills over here on the board. I'm just going to to make it a little bit larger over here. And the guy's sticking his arms out. So here's our trachea, and we know that the right lung is pretty big, and the left lung is a little bit smaller. It's got a weirder angle to it to allow for that heart to sit right there. But we know that the sternum, or midline of the body, is right there. Everybody follow me so far? We know that there's now 3 lobes in the right lung and 2 lobes in the left. If you think about where this comes down and how the carina would sit, a lot of times we know that with choking, for example, people actually choke above the epiglottis. And that's why, like the Heimlich maneuver, the maneuvers for complete airway obstruction in first aid classes, they work because we can easily push lung air up and pop the food out. But if someone actually has a piece of food lodged lower than the epiglottis, in the actual trachea, for example, let's imagine this is the food. When you look at the lung itself, because the right lung is much larger, the carina actually kind of leaves the bronchus almost at a perpendicular manner, so it comes down and then breaks off into the little branches and stuff. My amazing drawing skills. Whereas on the left side, because it's smaller, this one actually goes at a very steep angle. So if, just for a fun fact, as a paramedic, if I go to a call for somebody who's choking and it's deep down and I can't pull it out with my big scissors, I'll actually poke it down. I'll push it down the lungs. Why?
You can breathe with one lung.
You can survive with 1 lung. You can't survive with 0, right? So when I poke it, which way is it likely going to go? Down the angle. Because on this one, it would have to do almost a 90-degree turn to get into it. Now, I'm exaggerating the 90 degrees, of course, but it's much easier for it to flow down there. If you are doing a duty and you're doing resuscitation, paramedics come and we poke it down, and we say, hey, can you take a listen for lung sounds? Are you likely going to hear anything on the left side? No. But you should hear them on the right. The next thing, the reason why I'm pointing out this anatomy to you is if we're doing a resuscitation and a paramedic intubates, which we've talked about before, putting the tube into the lungs, that tube is meant to accommodate a variety of height people. So like if somebody has a little tiny neck like me, or if they have a giraffe neck, those tubes are relatively the same length, okay? So that being said, when somebody puts the tube down, we may also say, hey, can you take a quick listen to the lungs? We're more likely not only to poke the food down the left, but if someone's putting a tube in, it's more likely, because it's an easier angle, we may put it past the carina and you'll only hear lung sounds on the left. So if we ask you to listen for lung sounds, it's really important that we practice listening, because in that moment, we need it to be accurate. Are there sounds on the left? Yes, because my tube's down the left side. But I don't want my tube down the left side. I want it just above the carina so both lungs get oxygen if I can. Okay? So just some interesting facts to know. 2 different situations you may come across while you're on duty. Just make sure you listen and just tell them what you hear. Okay? Because it can make a really big difference. Now,
Sorry, Sandra.
yeah, for
Just
sure.
above the diaphragm, you've got something written there. I'm so sorry, but it's.
That's okay. Bronchioles. BRONCHOLIES.
Bronchioles.
And then what happens with the food in the lungs?
Not just CHO, it's CHI.
Oh, yeah, probably. Sorry, April.
Thank
The
you.
food that you get into your lungs,
Mhm.
then what happens?
So there's a couple of things. Like obviously, a surgeon might have to cut you open, take it out. But the more common way is right in an emergency department. They have, you know how I've showed you before about when I'm going to go intubate, I use that little laryngoscope and I look to see where I'm going.
Yeah.
There's a longer one that looks like a big black snake that the physicians write in Emerge. Usually they prefer an OR because it's cleaner. They can put right down into the lungs, and it's got little pinchers on it, and it just goes in, they see it and go, and then
While they're
pull it.
ultrasounding?
Not ultrasound, this is literally, I'm looking in this tube, in this little camera, TV screen that's attached to it, and go, it's like
It's like
driving a little
That's
car.
not a laryngoscope.
It's not a laryngoscope, it's called a bronchoscope, because it goes down into the
Yeah.
bronchi, bronchioles. Yeah.
It's like a little toilet snake with a camera.
Yeah, exactly. Like a little toilet snake. I am gonna make sure that when I'm in Emerge and they pull out a bronchoscope next, I'm gonna be like, hey, look, there's the toilet scope or toilet snake.
Small amounts of food that people choke on.
So that's where,
And they're fine, but
Yeah.
they
so if the food is in there, most people, again, thinking of the angles in which our lungs are from the carina. Again, sorry about my crappy drawing skills. If you're gonna choke on food, again, we know it's way more likely to go down the easier, steeper angle. But if it's in a young person, our cough reflex is pretty good. We can usually cough enough that eventually it'll come out. I'm sure all of us in this room at some point have choked on something, and after like a couple of minutes, you're like, and then it's like, there's that piece of corn, delicious.
and then you swallow.
And then you swallow it or spit it out, okay? The problem is that people who have a poor cough reflex, elderly for example, people with lung diseases or disorders, they don't have a great cough reflex to get that out. The food is an example, but it could also be like snot, it could be me touching stuff. Chelsea's got, you know, a bug of some sort, cold, and I'm rubbing it all over my face. It could be me even getting that bacteria into my lungs because I breathed it in, and now my cough reflex isn't good to get it out. So when the food kind of goes down and gets stuck in like the twig areas or in the alveoli, or if the bacteria gets stuck down there and it festers because you're not coughing it up, what's that called? That specifically is called an aspiration pneumonia, but in general, it's a pneumonia. Pneumonia is a bacterial infection of the lung, deep in the lung, and it's important to know this because as things are, you know, trying to fight, your immune system is trying to fight off that bacteria that's growing and just kind of like festering, it's going to cause inflammation and swelling. It will also, because it's breaking down and like itself growing, it's going to create a fluid, okay? Whenever, so I know this is a dumb drawing, but I'm going to draw some water here because the pneumonia's got some fluid in it, just full of pus and yuck, okay? When we listen to the lungs, we want to hear clear breath sounds, which would be no other sounds associated with it. But in the case of a pneumonia or fluid in general, what does it sound like? Raspy. If you think about at some point in your life when you've had like a glass of milk and you've had a straw and you blow back, what's gurgly?
Crackles.
It's called crackles, okay? So crackles is air movement through fluid. Everybody likes to say air movement through water, but in this case, not water, yucky water, right? So if you hear crackles or gurgly on one side, usually the left, it's probably a pneumonia. Let's go back to what we were just talking about and what we talked about last week with congestive heart failure. We know that on the left side of the heart, so we're gonna do our 4 chambers, that is not to scale. So we know that if this person sustained heart damage, especially to the left ventricle, it's not going to have that forward movement out to the aorta. And instead, we know, as we just chatted about, it's going to backflow to the left atrium and then backflow to the lungs. So when it's congestive heart failure And Mr. Congestive Heart Failure got up and was like, I'm gonna do extra work that I normally can't do. And my heart is trying to pump harder because my heart rate's higher because I'm moving. What's gonna happen is there's gonna be fluid backing up, but it's gonna be backing up on both sides. So if you listen to Mr. CHFer's lungs, and there's on both sides, it's more likely that he has a congestive heart failure episode going on. If you listen to somebody's lungs and it's on one side, it's more likely a pneumonia or other infection. Now,
Consider W.
that's where I was gonna get to, is a bilateral pneumonia would be on both sides. Bilateral means both. Here's another fun fact about fluid. If it's a pneumonia and it's festering in one spot, think about an infection you've had in your life. Let's say you had a fungus or a nail infection on your big toe. When you turn and you point your toe, kick it behind you, does that fungus move anywhere with gravity? No, it stays on the toe. A pneumonia, it's got this festery yuck. If I was to lay down, there's not enough actual liquidy water type fluid. When I lay down, when I sit up, it stays in the same spot. A congestive heart failure person, it's all liquidy fluid, okay? When that person tries to lay down, or you try to lay them down, you are gonna have them stare at you for like 1 second before they punch you in the face to sit back up. Because now, right now if they're sitting, gravity's holding all the water down. Yeah, so if you lay them down, now the water spreads out to the whole upside down tree and they're drowning. They feel like they're drowning. A CHFer will not let you sit them, or not let you lay them back at all. Yeah, so it's a common thing, like as a paramedic, if in the middle of the night I'm going into someone's house and they're complaining of chest pain, oh, I'm a little bit short of breath, yeah, and they're sitting upright or sitting kind of like semi-sitting on their bed, I'll look to see how many pillows they normally sleep with. Because if they can't sleep laying down, that tells me their CHF is not very good, and it lets fluid go everywhere and they can't breathe. So they naturally, people with CHF will naturally just add pillows and eventually they're almost upright. Interesting fact, right? So there's the difference. Those were a couple of things I want to talk about tonight. We'll just check those off the list. So pneumonia, a bacterial infection on one side treated with an antibiotic. Here's the other thing. We know that we can use an SpO2 monitor here, and we've talked lots of times about what an SpO2 looks at. Remember the raft on the river? To make sure that the 4 seats on the raft have some sort of gas on them. Hopefully it's oxygen. So if a pneumonia is on Mr. Smith, we're going to call him Mr. Smith. If a pneumonia is on Mr. Smith's left lower lung, it may impede oxygen from getting off the raft and going into the blood, and carbon dioxide from jumping onto the raft or off of the raft into the lung to get out, okay? But Mr. Smith's lung function over here, all of his gas exchange can still happen. So his oxygen saturations don't tend to go low. People get confused by that when they're diagnosed with a pneumonia, they've been in emerge, and the little alligator sits on their finger and they're like, why does it say 98? It's because the rest of your lung isn't affected and you're still doing good gas exchange there. A pneumonia doesn't necessarily present with a dropped saturation. It's not going to really be helped if you pour oxygen into these people. Years ago when I started as a paramedic, anybody who was complaining of shortness of breath got a non-breather 15 liters a minute. We've now learned that that's pointless because they're still having good gas exchange everywhere else, okay? The CHFer, that person, he needs oxygen because that fluid is everywhere. He's not having good gas exchange. His SATs will be low, very likely, okay? Cool. Any questions about that? So we've talked about pneumonia and pleurisy. The next smaller thing that's not as common but you may come across is this season, or this time of year, is really common for 2 different pediatric respiratory illnesses. Sorry?
RSV.
Those ones, that's viral infection. We're not talking about viral infection. These are ones that are really common. Yes, RSV is common this season, but croup, and epiglottitis. So, again, we're gonna say this is Jimmy, little Jimmy. Jimmy, in fact, okay? So Lil Jimmy, here's his epiglottis, and here's his lungs. Oh, that's not a lung. So here's Lil Jimmy's lungs, okay? Croup, also a bacterial infection that affects and causes inflammation of the airways themselves. Okay? So that means the little trachea here, it'll have some swelling on it. It's undergoing an immune response to the invading pathogen. Okay? So it's going to create some swelling, and by narrowing a tube, instead of hearing crackles, fluid, what sounds are made when tubes are narrowed? You're really Strider. That's right. So wheezes can also be present. Wheezes tend to be more deep down in the trunk and the branches, but not the trunk, the branches and the twigs and all that. This is where a lot of wheezing happens down deeper, but if it's here in the throat, it's stridor. S-T-R-I-D-O-R. Great job, Bonnie and Vera. So stridor is a high-pitched noise. When you've blown up a balloon before and you've grabbed the little sides of the balloon and you pull it and it goes, that's stridor. Okay? I do have actual lung sounds for you to hear in a few minutes, okay? So croup is creating inflammation, usually here in the tree trunk, that creates a high-pitched noise. Most of us, when we were younger, have experienced croup, okay? Commonly, croup is like aged 6 months to about, on the high end, 8 years. Can somebody who's 10 have it? Sure can. When I was 6, I had croup, and back then they used to put you in a humidified tent and all that kind of stuff. My brother, James, he was just about to turn 11, and he ended up with croup too. So older kids can get it. Can croup happen in adults? Yeah, of course, but so can everything else, right? It's not likely, but it's possible. Croup most likely will not kill the kid. What do they need? I just told you what the treatment was in the 80s.
Well, they need moisture.
They need moisture. So quite commonly, again, paramedic middle of the night is usually when we're gonna see it. Kids trying to sleep, can't sleep, they're coughing. Mom and dad are panicking, what the hell is wrong with my kid? The ambulance is called, we get there. Before I even get in the house and up the stairs to where the kid's bedroom is, where mom is, dad's at the door fretting, oh my God, he can't breathe. We're walking in the door, and as soon as we hear, kid's got croup. What do? Best treatment?
Throw them in the shower.
Well, I'm not gonna throw a kid in the shower, but humidity, so if this was your own child and you knew that this was croup, hot shower, not in there, but like humidity.
The
Or-
vaporizers that they have, where you can see, like, it almost looks like a spirometer, and
You
they,
can
like,
use
breathe
those.
in, yeah.
Outside air. Even the cold air can help decrease the inflammation, and the stridor can actually go away. So many times I have not had to give a croup child any medication. I just literally go, okay, let's go to the hospital, take them outside in the cold, and then we take our time, just a couple extra minutes, getting them on the stretcher outside in the colder air, into the back of the ambulance, and then by the time we're in the back of the ambulance, stridor's gone, not in respiratory distress. Okay? The difference between this and epiglottitis is huge. Using the word epiglottitis, what is it?
Swelling of the epiglottis?
Exactly, Glenn. So the epiglottis, the little flappy door that's protecting the airway from stuff going down into it, this little guy, he has a viral infection, and it's going to cause him to swell much bigger. So if a normal Lil Jimmy's 5-year-old epiglottis is this, epiglottitis makes it a big fat leech. How easy is it to move that little epiglottis up and down? Pretty easy. Big fat leech one, he's gonna struggle.
Almost suffocating.
Exactly. So epiglottitis, you can't see it, but people have tried where they put like a tongue depressor down and try and look to see if the epiglottis is swollen. That's basically signing the kid's death certificate. And the reason why is it's so fat and so big, if you're looking in the airway and trying to look down, you can actually push the tissue around it, irritating this fat leech, and all he's gonna do, flop over, which is going to close his airway. And the only way to fix that, if it's sealed shut, is a tracheostomy or a cricothyroidectomy. So a big needle in the throat, into the airway, into the trachea.
Cause it goes underneath the epiglottis.
Exactly. So how do we know the difference? Epiglottitis kids may also have a stridor. Kids in general, when they're having a hard time breathing, will do what's called the tripod position. Adults can do it too, it's very common in kids. Tripod being, your body is one of the legs of the tripod, and your arms are the other two. So 3 legs, tripod, and they're sitting forward. A kid with croup often is just like, a kid with epiglottitis, anything going down the throat will irritate it. So quite often the kid's leaning forward, tongue is out, and they're drooling. All of their saliva, they don't want to swallow it because it hurts, and they'll just drool it down their face. So if you're ever at a situation on duty or whatever, it's somebody set up a camper nearby or whatever, kids leaning forward, very short of breath, you can see they're flushed red, feel their skin, is it warm, signs of an infection, and their tongue is out and they're drooling. Don't even put oxygen on this kid unless it's a resuscitation. You literally just be as calm as you can. You call for an ambulance, and then you just say, okay. Don't even take the kid's blood pressure. Don't irritate the kid. Don't make them upset or cry, because that's going to cause more irritation here and can cause that fat slug to close. Okay? Big difference between the two. Okay? So, again, hopefully you'll never ever see epiglottitis. Honestly, 20 years, I don't think I've ever seen epiglottitis in its true form where the kid was going to die. Okay? Croup, I see that every winter, probably 50 times. Super, super common. It can happen in the summer, more likely to happen in the winter. Just like all respiratory infections, because we're inside breathing each other's gross. Okay?
Now in the summer, it's more like a dry season, isn't it? When it comes up.
Dry season. Not
There's
sure.
not a lot of moisture in the air, you don't have
Probably,
the same
yeah.
pHs and everything.
Well, there's humidity in the summer though, right? So you think that would be
Well-
helpful, but
We go through a stretch in August,
where it's dry
the
heat.
10th through 19th.
Wow.
where it's really dry, like when you breathe, it's like burning.
I've not seen it be more prolific in the summer at all. Most respiratory infections, especially, just like COVID and everything else that we've experienced the last 3 years, which feels like 20, the more inside we are with HVAC system recirculating the air, the more likely you're to get infection. But it could happen in the summer for sure. I'm not saying no, but I've definitely seen it way more in the winter. 'Tis the season, right? Okay, the last couple things that we need to talk about is asthma. So we said that Lil Jimmy's croup is up here. If we're going down his, not trunk, limbs and branches, okay, and it starts to get irritated by something that little Jimmy has breathed in, or the tissues around those that create those tubes for air to go in and out become inflamed, they can actually create like a mucus protection layer for them. It's just like your nose filling with snot. It acts as a plug. So little Jimmy's been exposed to, I don't know, paint fumes. And the paint fumes are irritating the lining of the airway. It's gonna create an inflammation and a mucus plugging. That is asthma. Asthma is repeated attacks, usually relatively short duration, where mucus and irritation and inflammation happen. And if it's bad enough, the wheezing that is created because it's deep down can actually create a silent chest. And the silent chest would be because this is so small that you don't even hear any air going in and out. Okay, so wheezing, it's more of a musical sound, and it's usually deeper in the lungs. Okay, versus stridor is higher up in the airways. So this is easily treated with what?
Inhaler.
What type of inhaler?
Steroids.
Salbutamol.
Salbutamol,
Corticosteroids.
which is also called
Ventolin.
Ventolin. What color of inhaler is it?
Blue.
Blue.
The blue inhaler is the only rescue inhaler that there is. Okay? All the other colors, pink, red, brown, orange, purple, green, they are all steroids that prevent this kind of thing from happening based on your pathology. So if you have asthma, you're more likely to be on like the red one, the Flovent, to prevent asthma attacks. If you've got a COPD, which we're going to briefly talk about next, you're more likely to be on the others, Spiriva, Advair, etc. Okay?
What's the orange one?
The orange one is Flovent, salmeterol, I think it is, and it's a preventative as well. So asthma kid or asthma adult is going, oh my God, I'm having an asthma attack, and they're wheezy. You take a listen to the lungs, and you're like, oh, that sounds kind of gross. They pull out their orange inhaler, and they pull out the blue one. You're doing blue one first. How do we use a blue inhaler?
Breathe out as much as you can.
Yeah, so most people here, the problem is that deep down in their little alveoli, there's still air in there that's trapped because it can't even get out, let alone air coming in. So they're gonna try and breathe out, but the reality is asthmatics and true asthmatic, they're gonna have
I
a
am
real hard
asthmatic,
time. Yeah,
so
so you know perfectly well.
I know what it's like to
Yeah.
try.
But good luck. But yeah, try and get them to breathe out. And then you're going to help them take their prescribed medication using the 5 rights as we've already discussed last week. And when the inhaler is depressed, it's going to shoot out an aerosolized powder that's inside of this canister inside. It's going to come out as a aerosolized powder. We want them to breathe in as best as possible. So as Bonnie said, you breathe all the way out as much as they can so that they can try and take as big of a breath in. So you're going to push down once. And then what is the patient going to do?
Hold on to that breath.
Nope. We don't want any more air trapping anymore. If they can get air in, we don't want it to sit there. We want it to go in. And the reality is it's probably not even going to get in down here where it needs to be. You're actually going to have them breathe in and out 4 times.
That's not what I was told.
Well, this is the current standards. So 1 squish down, 4 breaths. After they've taken 4 breaths as best they can, preferably if you have an aero chamber, which is going to keep that powder aerosolized, and they suck on the end of it, you're going to then give 1 more squish. And then what is the patient going to do?
4 times.
4 times. And then after their 4 breaths, you're going to do 1 more, and they're going to breathe 4 times, and you're going to do 1 more times 4 breaths. So it's
4 shots.
1 puff every 4 breaths. Okay. Now, if you look at a prescription for most rescue inhalers, it says like take 2 to 4 puffs. If someone has really bad asthma, as Bonnie has experienced, myself have experienced, you're going to give them 4. Okay, so you're going to do 1 puff every 4 breaths times 4 total puffs. Then you're going to wait for a couple minutes, usually 4 minutes, while that person hopefully is continuing to breathe on the end of their aero chamber to try and get in every last little aerosolized powder piece in as much as possible. And with every little breath that they can take, more and more is likely to get down there by the little puffs and make the difference. And by having that steroid get down here, it's going to slowly ease off the mucus production and the inflammation, opening the airway. Then you, after the 4 minutes, they're still wheezy, we're gonna go back and we're gonna repeat this, okay? Technically, there's no maximum dose of Ventolin. Bonnie, when you've had your Ventolin, what do you feel like?
Thank God.
Thank God I can breathe. What other symptoms do
I thought
you have?
said, like God.
Like God. I am God with a small
I
G.
get lightheaded.
Lightheaded. Why? Why would Glenn get lightheaded?
Of the breathing.
So he can now breathe.
You got a lot of oxygen.
You open up the airway,
Okay.
Heart rate.
boosting more oxygen going up to the brain.
You're more likely to get lightheaded because before it even has that effect, one of the side effects of Ventolin is it also sits nicely in your cardiac receptors that make your heart rate jack up. So now you can barely breathe, you don't have lots of oxygen in you yet because
But
it's
your
still
heart
working,
rate's very
but your
slow.
heart rate jacks up. So now no oxygen's getting up to your brain because your heart rate's pushing around stuff that doesn't have any oxygen in it. But then as Bonnie says, all of a sudden it's like oxygen floods to the brain, the lightheadedness is still there for a minute until it goes, oh, there's what I needed, some oxygen. And I'm good again.
I was in the hospital once and I swear to God I had like maybe 30 puffs.
Oh yeah, there's no
was-
maximum to it.
Yeah,
You just
was-
have to be careful with people who, like, let's say I have a high heart rate and I have heart damage, like I've had a heart attack before. You may want to be a little bit easier with jacking my heart rate, not to kill me, but
But the doctor was the one who said, you know, keep her going on it.
yeah,
you know.
take as much as it needs to get relief, but you have to it's just like any medication. If you have a headache, you take some Tylenol, do you expect instant relief of your headache? Yeah, I know, right? If only. But it's going to take a few minutes, probably 30 minutes before there's any type of actual reaction because the body needs to break down and metabolize some of that medication. It's the same with this. You giving 4 puffs and then waiting the 4 minutes, you've got to wait because you've got to let it kind of like work its way down deep where all the yuck is. Make sense? So what's the difference between asthma and chronic bronchitis, which is a COPD? Chronic obstructive pulmonary disorder or disease.
Like diagnosing wise or?
It's presentation.
Chronic, so it's constant.
Boom. So, chronic bronchitis.
If you get bronchitis X number of times within a year or within so many months for so many years.
Yeah, so it always changes the specific way they're going to diagnose it. The last one I think I've heard was like, you've had bronchitis for at least 1 month for 3 consecutive years. And ultimately what that's going to do is exactly where the asthma inflammation is, and farther down into the branches and the twigs, it's chronically inflamed. It's not creating a mucus plug, it's just chronically like swollen, we'll say, making it more turbulent for the air to get down and a little bit more difficult, which again means that deep down here in the little alveoli, air is going to get trapped. And not only air gets trapped, like oxygen gets trapped. What else gets trapped? Carbon dioxide.
CO2.
What happens when you don't have enough oxygen in your system? What color do you turn? Blue. So you turn blue. So a chronic bronchitis patient has a chronic condition where there's inflammation, itis, of the bronchi or bronchioles as it's working its way down, that creates air trapping, and CO2 is like very prominent in there. So
what
they
does-
turn blue.
What does COPD stand for?
Chronic obstructive pulmonary.
CHRONIC,
Blue bloaters.
obstructive pulmonary disease or disorder.
Think puffers and blue bloaters.
Yeah, so when some of you have been in the MFR classes with me before, where I've explained a chronic bronchitis person, because they've got air trapping, they tend to be chronically blue, and they're trying to push the air out of the inflammation, and they do that by, as Bonnie said, trying to push all of the air out they can. So if you've ever seen a walrus, actually, you know what, Brandon, for New Year's Eve, took me to Quebec City, and I finally got to see a walrus for the first time in my life. Oh my God. His name's Morris. I love him. I have lots of pictures of Morris. And he literally just goes,
Very big.
Yeah.
so think of a chronic bronchitis like a big blue walrus. They tend to be a little bit round in the tummy. They're blue, and they're sitting there going, blah, blah, blah. That's literally how they present. I can't breathe. They're trying to get this stuff out. Okay, so that is one form of COPD. The other form of COPD, and just so that we remember the chronic bronchitis guy, again, sorry about my shitty drawings. This is gonna be Morris. Oh, I think this is pretty good, folks.
Yeah, you're better at this.
Blah.
Where's his fangs?
Oh, yeah, sorry.
His tusk, or what are they called?
And
There
his,
we go.
so he had little hairs too,
Yeah.
and he had a little black
That's
eye.
pretty good.
Thanks, friends, thanks. So, blue bloaters, chronic bronchitis. Always remember, chronic bloater. Chronic bronchitis is the bloater, okay? The other type of COPD happens not in the tubes or the branches going down, but instead, those are actually pretty much fine. But where this person's damage is down here in the little alveoli, which are supposed to look like a bundle of grapes. So the problem with a COPDer who has the deeper issue, which is called emphysema. So emphysema, basically, remember what we've learned before about gas exchange? So our pulmonary artery is bringing dirty carbon dioxide blood back, and it goes all around these little vessels to pick up oxygen and drop off carbon dioxide. But this emphysema person has been smoking for years. They caused chemical damage to the actual grapes. And what happens is these grapes, they start to collapse in on each other or explode. So then all of a sudden, these two little grapes become a bigger grape, which means the blood vessel that was between them no longer can do gas exchange. And then the blood vessel right here gets broken off because these two combine. And then these two combine. And you'll notice, the more these combine, the less blood flow can occur to them and gas exchange can happen. So over time, all of these little tiny grapes start to break apart, and you've got like shrapnel of the old tissues left. Very, very little bit of blood circulation, so there's a little bit kind of going around here. And so even though they're getting air going in and out, when it gets down here, the oxygen isn't going into the blood vessel, and the carbon dioxide isn't coming off. So this person will perpetually have, throughout their body, floating around on the raft, lots of residual carbon dioxide because they can't get it off the raft. The emphysemic, why I drew it in pink, they're called the pink puffer. This person is always breathing faster and harder, trying to get more air in and out because they can't exchange very well. So the increased rate of breathing means they're trying to get some of that gas to happen. These people tend to be thin, emaciated almost, like they're super thin. You lift up their shirt, you can actually see their rib cage because they're burning off all of their excess fat stores, trying to keep themselves alive and allow gas exchange to happen. They're chronically CO2 in their body, making them pink.
Don't they go?
That's right, a pink puffer will go, it's called pursed lipped breathing. They're trying to blow off the CO2. There's nothing blocking the movement. It's all down here. And it's usually because of smoking, exposed to things like asbestos, chemicals, etc. A lot of people end up with emphysema who never smoked a day in their life because they were a waitress in a diner for 40 years. Secondhand smoke, right?
Now, if I remember right, when you come across one of these, you can't give them full oxygen.
Yes, so next week we're going to be doing PCRs. And in that, before we start that, we're going to talk about how we would treat the COPD patient versus the asthmatic who is blue and can't get air in with drugs and oxygen for that case. Okay, so just remember that we've learned a bunch of different pathologies for the respiratory system. A common one you're going to come across is asthma. We know that's temporary, repeated attacks of shortness of breath caused by mucus plugging and swelling. Then we have COPD, which has two different forms. One is chronic bronchitis or chronic bloating, Morse the walrus, where CO2 is stuck. And then the pink puffer, the emphysemic, where air's flowing great, but they